Welcome all. Let us start with the new video in the series. So the series termed as Oncology for Non-Oncologists. Oncology for non-oncologists. The first series we just told how do we name cancers. The next series we'll start what are the differences between malignant and benign tumors. The first series we named what are benign tumors, usually called omas. Malignant tumors based upon the cells of origins, either called sarcomas or they are called carcinomas or lymphomas or leukemia. So sarcomas, carcinomas, lymphomas, leukemias are the malignant cells, and the rest omas usually are the benign tumors. Let us start with morphological characters between what are the differences, what are the similarities between benign and malignant tumors. So what are the morphological characters of the malignant tumors? Why malignant tumors behave differently? So when I termed about morphological characters, this is what we can see. So what we can see, we either can see with our eyes, either we can see with our microscope. So usually what pathologists do. Let us see what are the different things, as we told earlier, what are the things that we see in a malignant tumor. So what we see different things in the malignant tumors, they start with differentiation, with pleomorphism. We see nuclear changes, which is appreciated with the help of a microscope. The mitosis, which is appreciated with the help of microscope. Loss of polarity, necrosis, local invasion, and metastasis. All these are the changes. All these are the changes that are not usually seen in normal cells, but specifically seen in malignant tumors. Now, let us start with differentiation. What is differentiation? Differentiation refers to extent to which the neoplastic parenchymal cells resemble to the corresponding normal parenchymal cells morphologically and functionally. So this differentiation helps us to say whether this particular cancer or this particular tumor is a cancer or not. So based upon degree of differentiation, though it's not seen in all the cancers, we can say whether this tumor is malignant or it is not malignant or it is benign. Let us start. So what are different kinds of differentiation? So there will be benign tumors which exactly appear like normal cells, exactly appear like well differentiated tumors, and they are again malignant disease which appear different. And between the benign tumors and malignant disease, there are different kind of things. All these things either predisposed to cancers or just precursors to the malignant cells. The other things that we reach is metaplasia, dysplasia, carcinoma in situ, and the malignant disease. So differentiation in benign tumors are usually well differentiated. The neoplastic cells of lipoma, a proliferation of benign adipocytes, may be so closely repelled to adipocytes and it is unrecognizable as tumor in a microscopic exam. With regard to lipomas, it's a most common tumor, not a malignant tumor that is seen. In fact, I do have lipomas other than the fat that I have. So lipoma is the proliferation of the benign adipocytes. It resembles very closely to the normal sites, and most of the times it is unrecognizable in microscopic examination that it is a different kind of tumor or it is a tumor as such. So then are the other things, leiomyoma, which is a benign tumor. It resembles the smooth muscles of the uterus. Then there is adenoma of thyroid, which resembles the normal cells. But how it is differentiated, there is a growth, and the biopsy from the growth is similar to what it is usually present in the thyroid. This says that it is not a malignant cells, but rather a same cell of the tissue that it is derived from. It is tumor because it has grown beyond. It is not usually present in other parts, but usually these are not these tumors are benign. They are not dangerous. They can be cured with surgery. So what is metaplasia? Metaplasia is defined as replacement of one cell with another cell in association with tissue damage, repair, or generation. Where does metaplasia happens? Due to chronic irritation or due to doing things that are not due to exposure of certain kind of processes which are not inherent to that particular tissue. The cells change. Why does it change? Usually it is the genetic things. So what happens, the genes recognize that different kind of processes are happening around them which they are not designed to chem, so they change the genetic expression of their proteins, and finally the architecture of the tumor is also changed. This change in the architecture, though not malignant, can predispose that particular area to form a malignant cells. So usually what happens, often by replacing the cell type, it is better suited for some alteration in the local environment. Unfortunately, this is more prone to metastatic or malignant transformation. Examples are, the two most common examples are Barrett esophagus. Usually the esophagus is not designed to take the stress of the acid, but in some cases there will be something called gastroesophageal reflex disease, where the acid, due to obesity or something, because of lack of a fixed valve or something, they just come into the esophagus, because the cells are not designed to get exposed to the acid. Slowly they change its morphology. This leads to replacements by glandular epithelium. So the squamous epithelium that is inherent to the esophagus is shifted to a glandular epithelium that is suited to the acidic environment. Then we have bronchial metaplasia. Bronchial epithelium, which is usually a squamous cell epithelium, in chronic smokers and chronic irritation will metastatize, and it will develop into a bronchogenic carcinoma. So these are two examples how a normal esophagus and a Barrett esophagus. If you see this is the normal epithelium. This is the normal squamous epithelium that is present in normal people. But when there is acidic reflex, if you see here, when there is acidic reflex, the acid goes beyond into the esophagus near the squamocolumnar junction. The cells get transformed into some kind of glandular epithelium, and this glandular epithelium, this change in the cells is called metaplasia. So this metaplasia also happens in case of lungs because of chronic irritation. So the squamous epithelium cells, which are usually sent, get transformed into mature columnar epithelial cells, and this is termed as metaplasia in the lung. So there is then another term called dysplasia. Dysplasia, a term that literally means disordered growth. It's still not cancer, but it is a disordered growth. It is encountered principally in epithelial cells and recognized as basis of several morphological changes. Dysplastic cells may exhibit considerable degree of pleomorphism, often contain large hyperchromatic nuclei with large nuclear to cytoplasmic ratio. But dysplastic epithelial surface also typically show architectural disarray or loss of orderly. Where we usually find dysplasia is in cervical cancer, where the dysplastic cells, though not fully malignant, they predispose for malignance due to chronic irritation. Why dysplasia happens? In cervix cancer, it is due to the HPV virus. Initially, the dysplasia happens. This dysplasia one by one transforms into carcinoma in situ and finally invades fungus squamous cell carcinoma. In dysplastic squamous epithelium, the normal progressive maturation of tall cells in the basal layer to flatten layers may fail, or part leading to a replacement of epithelium by basal-like cells with hyperchromatic nuclei. Dysplastic cells do have certain resemblances to malignancy cells. In fact, genetically, most of the genetic processes also do happen in dysplastic cells. So dysplasia is disorderly growth, metaplasia is different growth. As a brief definitions of dysplasia and metaplasia. So dysplasia is a precursor of malignant transformation. With the removal of inciting causes, moderately severe dysplasia may sometimes be reversible. This is something which is very different to usual cancers. Dysplasia is reversible, but it is carcinoma is irreversible, because that genetic event which causes the metastatic capability did not still happen in dysplasia. They have changed their environment. They have nuclear changes. They have increased proliferation, but they are not metastatic yet. They are not locally invasive yet. If they are invasive or locally metastatic, then we call as carcinomas. So dysplasia usually occurs in metaplastic epithelium, and not all metaplastic epithelium is dysplasic. So dysplasia is a precursor. We can find genetic changes. We can find malignant genetic changes in dysplastic epithelium or dysplastic cells, but metaplasia is not. But metaplasia does provide certain kind of genetical soil for them to transform themselves into dysplastic cells. So how this example, normal cells will be hyperplasia. Hyperplasia is just increase in the number of normal cells. Dysplasia is change in the cellular architecture. If you observe here, and cancer is something, it will invade, it will metastatize. So the definition has been here. It no, In dysplastic squamous epithelium, the normal progressive maturation of tall cells in the basal to flattened layers on surface may fail in part or entirely, leading to replacement of epithelium by basal-like cells with hyperchromatic nuclei. This can be seen here. The entire cells, the basal-like cells are transformed. They have a hyperchromatic layer. They are pleomorphic. Pleomorphic means different kind of cells that are present in the single tissue. If you see here, all the cells are similar. Here, the cell size vary, the nucleus vary because they are in different phases of cell cycle. And cancer, they have this two important capability called invasion of metastasis. Then the last form of differentiation, the carcinoma in situ, where dysplasia is severe and involves full thickness of epithelium but does not penetrate the base membrane. It is called carcinoma in situ. This carcinoma in situ is seen in skin, breast, bladder, and uterine cervix. In situ epithelial cancer display all the cytological features of malignancy and should be treated because they have high probability of progression into invasive cancer. So an example, it is carcinoma in situ here, and it is a cancer there. If you see here, it has not yet crossed the basement membrane. It is called carcinoma in situ, where it has crossed the basement membrane and it has this invasive component. It is called cancer. So differentiation in malignant tumors. Malignant tumors also have different levels of dysplasia. They are well differentiated, moderately differentiated, or poorly differentiated. The well differentiated tumors have these nuclear changes which say they are malignant, but otherwise they look like they're normal components. In contrast to benign tumors, which are always well differentiated, malignant, well differentiated, malignant tumors can be, benign tumors are always well differentiated, while malignant tumors can, the differentiation in malignant tumors can range from well differentiated to moderately differentiated to poorly differentiated. Well differentiated tumors have morphological features which are similar to the benign counterparts. The example for well differentiated tumors, there are many neoplasms which are well differentiated but still called malignant. The malignant nature of such tumors is revealed by invasion into adjacent tissues and their ability to malignate. How do you say a differentiated malignant tumor to be malignant? Because there are nuclear changes, they invade the adjacent structures, and they also metastatize. So we see, imagine yourself in front of a microscope. You just have a slide and you just put it into the thing and you watch it itself. The first thing that you see whether it is differentiated or not differentiated. If it is well differentiated, it is definitely, it may be a benign tumor or a malignant tumor. But if it is not differentiated, we can't say the tissue of origin. It is definitely a malignant tumor. So this is the first line or first thing that we see in a microscope. Once we see in a microscope, we say it is poorly differentiated and it is malignant. Then we go whether differentiated tumors, what is the range of differentiation? So if they are well differentiated, it may be benign or malignant. And how we differentiate patients, tumors which are well differentiated within Benign and Benign, there are other features that we discuss further. Examples are especially in thyroid, and where they are well differentiated carcinomas and they are undifferentiated carcinoma. Well differentiated carcinoma usually resemble their normal counterparts. Undifferentiated carcinoma usually do not. This is an example of well differentiated squamous cell carcinoma of the skin. The tumor cells are strikingly similar to the normal squamous cells, and in fact, they too have intercellular bridges and these are the keratin pearls. These are the keratin pearls. So then they have moderately differentiated carcinoma of colon compared to well-looking glands, which are characteristic of benign tumors. They are irregular in shape, do not resemble normal colon carcinoma. Then we also have poorly differentiated cancer cells where we can't say what kind of cancer it is. And the abnormal cell, if in this cancer, the abnormal cells has tripolar spindle. This is the tripolar spindle. If you can see exactly, it resembles that such kind of a mitosis is happening, and there are many different kind of cells happening in the same cell. And anaplasia is a condition where there are poor cellular differentiation, they lose the morphological characteristics, and lack of differentiation is a concept of hallmark of aggressive malignancies. The example for this is a lipoma. As told earlier, these are fat cells which are displaced nucleus. This is a liposarcoma, which doesn't even look like a lipoma. It is completely, it is poorly differentiated, and it has a huge cytoplasmic it has a increase cytoplasmic to nucleic to cytoplasmic ratio. We call these terms as aneuploidia. And what are the differentiation between well differentiated and poorly differentiated cancer? Well differentiated transplants have greater likelihood of retaining functional probability, but poorly differentiated, the functional capacities are decreased. So well differentiated thyroid cancers, for example, well differentiated thyroid cancers still secrete thyroid hormones, and they can be curtailed, or they can be controlled by iodine, which is usually taken by normal thyroid cells. Whereas poorly differentiated cancers, especially in thyroid carcinoma anaplastic, they lose the capability, they lose the function that is designated for the normal counterparts. In fact, they go back and they express the proteins, they express the substances which are not expressed by the normal counterpart, but expressed by the previous thing. That the example is alpha fetoprotein. Alpha fetoprotein is usually expressed by embryonal cells. It is not expressed in adults, but in case of poorly differentiated cancers, especially hepatocellular carcinoma, this hepatocellular carcinoma will de-differentiate and it forms certain kind of substances which are not usually formed, called alpha fetoprotein. Alpha fetoprotein usually is produced by the embryonal cells, but it is not produced by adult people. So other differentiation, they have the squamous cell carcinoma synthesize keratin, and hepatocellular carcinomas elaborate bile. Whereas poorly differentiated carcinoma, like bronchogenic carcinoma, may produce corticotropin, parathyroid like hormone, insulin, glucagon, other hormones. They also secrete, but that secretion is not the intrinsic function of things. So we have a chapter on paraneoplastic syndrome, but this is a definitive. This is an era to discuss about the paraneoplastic syndrome. Paraneoplastic syndrome are caused by certain kind of substances that are produced by tumor cells, which are not usually done by those tumor cells. So what, as we discussed earlier, the tumors go back to their embryonal cells. If we go back to embryonal cells, these embryonal germ cells are pluripotent. They can transform into any kind of cells, and similar, they can function in any way that is possible. This functioning in any way that is possible sometimes may lead to production of certain substances, and these certain substances may be responsible for paraneoplastic syndromes. Then another important characteristics is pleomorphism. Here we have two terms: pleomorphism. Morphism is morphism is the shape. Pleo means different. So it refers to variation in cell cycle and shape. So in a malignant tumor, there are cells with different size and shape. Why different size and shape happens? Because size of the cell is basically mostly dependent on the phase of mitosis they are. If they are in S phase, they have synthesized the DNA, they are in a different way. And when then functional, the cytoplasm is larger. When the nucleus is dividing, the nuclear architecture is different. So this kind of different kind of cells that are present in the same slide or same particular regions that you take about will also indicate that this particular slide or this particular cells that are derived are looking like malignant. The cells within the same tumors are not uniform, but range from small cells with undifferentiated appearance to tumor to gain cells that are many times larger than the neighbors. If you see here, we have normal cells. We have these are the normal cells, and these are the abnormal cells that are present. Sometimes there are two different kind of cells also. This is a slide of rhabdomyosarcoma, and there is marked nuclear pleomorphism, hyperchromatic nuclei, and tumor gained cells. So pleomorphism is one of the different characteristics or the characteristics that differentiate from malignant to benign tumors. Then the most important, all the things that happen, the nucleus is place where the chromosomes are in. Chromosomes are the place where the DNA is in. DNA is the place where the gene is in, and gene is the place where cancer, the difference between a normal cell and cancer cell happen. So what all changes that happen morphologically can be seen in the nucleus, because nuclear changes are the fundamental things that happen in the cancer. So characteristically, cells have nuclei that are disproportionately large, with a nuclear to cytoplasm ratio that may normally approach to 1:1 instead of 1:4 or 1:6. What does the nucleus do? What does the nucleus have usually? Nucleus has the DNA. What is the function of DNA? DNA just codes for proteins and all the substances. But what happens in malignancy? Nucleus starts dividing. And once nucleus starts dividing, the nuclear size increases. So as the nuclear size increases, the cytoplasmic cells size of the cytoplasm dwindles. So nuclear to cytoplasmic ratio, it's normally, what is the normally it is 1:4 to 1:6, but in malignant cells, if we observe, the nuclear to cytoplasm ratio decreases. So from 1:4 that is usually present here, it becomes to 1:1. So that's, it becomes almost half. And the nuclear shape is variable and often irregular, and the chromatin is often coarsely clumped and distributed along the microsomal membrane, and it is more darkly stained than normal. Abnormally large nuclei are also commonly seen in case of malignant cells. And the next part is mitosis. Cancer cells often contain many cells in mitosis, reflecting their high rate of proliferation. In presence of mitosis, however, doesn't not equate to malignancy. More important is morphologically is atypical bizarre mitotic figure. So there are 2 points that have been discussed here. One important point is both malignant cells, benign cells, or normal cells all contain mitosis, but the distinguishing feature in case of malignancy is atypical mitosis. Why does the atypical mitosis happens? As you go back, what actually happens in thing is, there is DNA repair mechanism, and this DNA repair mechanism is again of 2 types, homologous or non-homologous, mostly in cancer cells, because the mutations happen and the cells try to, the genetic architecture tries to correct it. There are different kinds of chromosomal aberrations, that are happening in the normal cells. Because the different kind of chromosomal aberrations happen, the spindle cells may not bind in a way they bind to normal chromosomes, and this forms a formation of different kind of spindle called atypical mitotic spindle. So atypical mitotic spindle is a feature that indicates that the thing that you're seeing is a malignant cells. The other part is loss of polarity. In addition to cytological abnormalities, the orientation of anaplastic cells with respect to each other or to the supporting structures like basement membrane is markedly disturbed. These sheets or largely masses of the tumor cells grow in a disorganized fashion. Let me explain about this one. Normal cells are arranged in a particular manner. So all the bricks form a wall. But when it comes to malignant cells, the brick is arranged. It is arranged in a particular manner to form a wall. So they are arranged in a way that a brick lies over a brick, lies over a brick. But in case of malignant cells, all the bricks are not arranged in the same manner. They lose their polarity. They lose their orientation to the adjacent cells. This loss of orientation to the adjacent cells can be a distinguishing feature, and this can help the pathologist to identify what is cancer and what is not cancer. So loss of polarity, again, one of the most fundamental is one of the fundamental thing that is distinguishing that the particular cell is a cancer. The next part is presence of necrosis. So what happens? The tumor cells grow in size, and these tumor cells are not capable or do not have their own blood supply till certain stage. Because these tumor cells grow in size, they have increased requirement. Some cells also die, and this death can be apoptosis or it can also be necrosis. It's a pathological death. So this necrosis is usually found in tumor cells due to increase in pressure, because they grow beyond the diffusion capacity of the blood vessels. You see here the cells which are very distant from the blood vessels undergo such kind of necrotic cells, and these necrotic cells will attract inflammatory mediators, and that's the reason in most of the cancer we do find inflammatory substance in the tissue that is taken off. Most important characteristic is local invasion. The growth of cancers is accompanied by progressive local invasion. By the term we call it as cancer, the initial term. Why it is called cancer? Because they adhere so tightly to it. This local invasion is usually not seen in benign tumors. Malignant tumors do not recognize the normal anatomical boundaries and can actively invade the surrounding tissue. And sometimes local invasion forms because body will be trying to stop the invasion, the cancer will be trying to go ahead. Sometimes certain kind of a neutral zone can form, which is called capsule. Mostly, this capsule is also invaded in malignant cells, unlike in benign cells, where capsule is not invaded. So capsule consists of extracellular matrix. It is deposited by stromal cells such as fibroblasts, which are activated by hypoxic damage resulting from the expanding of the tumor. So capsules are again of two types, true capsules and pseudocapsules. True capsules are usually present in benign tumors. It is because the benign tumors will grow slowly and expand slowly. They usually develop a rim of compressed fibrous tissue called capsule. Such encapsulation creates a tissue plane by which the surgeons can operate. So it can be easily operated. Well, pseudocapsule, it appears to be capsulated. It appears to be localized, but it is not localized because the slowly expanding malignant tumors may develop in apparently enclosing fibrous capsule and push along the borders front into the adjacent normal structure. They go beyond the capsule. So a capsule is not a definitive anatomical landmark in case of malignant tumors to say that it is things. So histological examination such pseudo encapsulated masses always show that this capsule, though initially appeared to be stopping the growth of the pneumonia mass, they have certain kind of malignant cells and they have this crab-like feature of growth which grows beyond the capsules. So example for a benign tumor, sometimes benign tumors also don't have capsule. Example is a hemangiomas, which is seen in this young beautiful kid. These are obviously hemangiomas are often unencapsulated and permeate the site in which they arise. Then such cells are extensive, they may be unresectable. Invasive ductal carcinoma of breast. On cut section, lesion is retracted and infiltrates the surrounding breast substance and it is stony hard in palpitation. So this is an example for invasive. You just see how the capsule is unable to contain the tumor. It invases into other things. So another most characteristic feature or most characteristic feature of this one is metastasis. So metastasis is the basic difference. Now, anything which has metastasis definitely should be malignant. It defined as the spread of the tumor into sites that are physically discontinuous with the primary tumor. If they are continuous, it is called local invasion. Only when they are discontinuous, they are called as metastasis. The likelihood of metastasis of solid tumor correlates with other features of the malignancy like lack of differentiation, aggressive local invasion, rapid growth, and large size. All these features indicate that there is a high chance of malignancy. What are the pathways of spread? There are different paths of spread. One is seeding of the body cavities. Second is the lymphatic spread. Third is the hematogenous spread and the iatrogenic spread. Iatrogenic spread, it means that it is a man-made spread. The important thing is seeding of the body cavities. It happens in ovarian cancer, gastric cancer, where the peritoneum, the body cavities are seeded by the tumors. It is mostly seen where all seeding can happen, where all the body cavities can happen, especially in pleural cavity, pericardial, subarachnoid, joint spaces may be involved. The most common it is peritoneal space. Pseudomyxoma peritonei is a mucus secreting appendiceal. Why appendiceal cancers usually present with pseudomyxoma peritonei is it is similar to colon cancer, but the lumen of appendix is very small. This small appendix, when the tumor develops, usually bursts, and these cancer cells are distributed entirely into the peritoneum. And because peritoneum is unhematopoietic structures, they grow without any anatomic constraint. They move from one place to another place and finally end up in pseudomyxoma peritonei. So what is pseudomyxoma peritonei? It is a metastatic cancer that is present in the peritoneum, that is derived in the appendix. Next, another way of transform is, if you remember in the last slide or the earlier slides, we see that this tumor composure also has lymphatic vessels. And there are also blood vessels, but the problem is blood vessels are so small that they usually cannot disseminate the cells. So the cells, before getting those metastatic capabilities, initially transfer through the lymphatic vessels. So this lymphatic spread usually happens in all the cancers because these lymphatic vessels have a large bore and the cells are taken. Cells and also the immune system recognizes the cells. So what is the advantage is these cells transfer to the lymph nodes and they are contained in the particular lymph node site. That's why we find lymph nodal enlargement. So though there is lymph nodal enlargement, we say it is loco-regional rather than metastatic because the lymph nodes act as a barrier for the cells to grow beyond the lymph nodes. That is called lymphatic spread. The second thing is hematogenous spread. Here the cancer cells directly get access to the blood vessels. So because they get access to the blood vessels, they go and they flow the path of the blood vessels and deposit to the first site that they usually hematogenous spread actually usually happens due to venous plexiforms because they are wide bone. So in general, histological evidence of penetration of small cells at the site of primary neoplasms, ominous features associated with hematostasis. Usually it happens in the veins. Arteries are less. There is less probabilities that tumors invade the arteries or go enter into the artery tumor cells, because arteries have thicker walls and they are more resistant to penetration. So this is an example of cancer metastasis. This is a liver cancer. Most of this metastasis happens to portal system, because the colon is supplied by the most common colon cancer usually metastasizes to the liver. So it mostly happens in case of colon cancer. This is an example of metastasis. So metastatic cancers have the same properties or morphological properties or microscopic properties that resemble to the original cancer. That's why they are called metastasis. So these are patterns of head and neck cancers. The most common site of metastasis through blood vessels is the lungs. The pathway of spread is caval blood. It's gastrointestinal cancers, it is the liver to portal bed. Thyroid cancers is the vertebral column through prevertebral plexus. Prostate cancer to the vertebral column through prevertebral plexus. Renal cell carcinoma, inferior cava, it happens because there can be direct tumor extension. So the renal cell carcinoma formed, these cells transfer into the inferior vena cava and extend up to the extend beyond the abdominal aorta, beyond the inferior vena cava. Hepatocellular carcinoma usually spreads to portal and hepatic radicals. Iatrogenic spread, it is a spread caused by the procedures that we do. It has very less probabilities, but the important why we need to is, before doing a biopsy of the tumor, we need to be very careful so that we don't disseminate the non-disseminated tumor. If the tumor is not metastasized, we should not metastasize. This is usually applicable in musculoskeletal cancers, also in Wilms tumor. Especially in Wilms tumor, we upstage the disease. Once a biopsy is done, instead of, though the tumor actually according to the size and other characteristics stage 1, because of doing biopsy, it may be upstaged to stage 3. So that is iatrogenic spread. So among different kind of spread, lymphatic spread, local invasion, hematogenous spread, and the other one is iatrogenic spread. So just a fun quote: cancer prefers to figure things on out of their own, because cancer cells find out a way to survive. Thank you. This is the end of this session.